Thank you so much for your kind invitation. And I would love to have a discussion with all of your team later on. And now I'm just going to share my screen. Okay. Let me just. Okay. So as you can see, and as obviously you know, the title of the presentation and the topic, it's going to be more about sleep and preclinical stages of Alzheimer's disease. And I'm going to be bridging evidence from the multimodal studies using both neuroimaging but also fluid biomarkers. And obviously we have only 1 hour, so I won't be able to maybe touch on the digital wearable devices that I'm currently now using or setting up for my study, but would love to take that further in the discussion. So this is just a quick overview of what I'm going to cover today. So I'm going to start talking from why sleep really matters in aging, because I think, you know, this is where what we are here for, and also looking into the evidence of sleep in Alzheimer's disease patients, because that's the historical inception point of our research in this field. Then I'm going to move talking and highlighting the bidirectional relationship that we are all aware in this field, and going to draw on some clinical research, and mostly I'm going to feature some of my recent work for you today, looking into the multimodal methods. And I would also like to highlight the obstructive sleep apnea as a big player in this relationship, and also briefly introduce the emerging role of orexin system, not only in sleep, but why has it been so highly talked about during this year's AAC conference. But before we actually dive into the topic and into the research, I would like to actually step back a little bit and start looking into the meta picture. Why does aging really matter, and why are we all studying it? Well, simply put, the world population is rapidly aging. And this graph on the left side of the slide actually illustrates that really well. If we zoom in at the midsection of the graph, we can see this is the time moment where we are right now, so 2022, 2025. And according to the prevalence rates, we have around 10% of world's population, which is over 65 years. And if we fast forward around 25 years in the future, so to 2050, we see this number is going to increase by 6% to 16% of the population being age 65. And if this number is not too big for you, we can then really take the time machine and go all the way to the end of this graph, to 2100. It's even difficult to say such big of a date, but the predictions state that by then we're actually going to have 1 in 4 individuals worldwide that are going to be aged over 65 years of age. And obviously with this staggering aging numbers comes a lot of health problems, including cognitive decline, cognitive issues, making it very critical for us to actually understand what is happening in this aging process and how it affects the brain health. And while I'm sure like most of the audience is very well familiar with Alzheimer's disease, so I'm not gonna linger on the basics, but I would like to focus on the preclinical stage of Alzheimer's disease, which is a period during which the pathological changes, the hallmarks of Alzheimer's disease, such as amyloid beta, plaques, and tau neurofibrillary tangles already start to accumulate in the brain, although in the absence of any cognitive symptoms. And what actually makes this stage particularly significant is that it can begin decades before the onset of clinical symptoms. So why does it matter? Well, actually, the importance of study this preclinical stage or asymptomatic phase of Alzheimer's disease lies in actual potential of it being a window of therapeutic interventions, because we know since brain pathology of Alzheimer's disease is largely irreversible, once the symptoms start to become evident, the preclinical stage thus offers us this time frame where potential therapeutic interventions could halt or slow the progression of the disease. So we covered the aging, we covered the preclinical Alzheimer's disease, but where does sleep actually come into the picture? When I would again want to resort to the numbers, because they do sometimes speak more than words. And I would like to highlight this quite a landmark study by Foley and colleagues where they looked at the sleep symptoms and sleep quality metrics in a huge cohort of community dwelling older adults, which were cognitively unimpaired. They had a really nice size of almost 10,000 individuals from the US, obviously. And what they found was quite striking, that more than 80% of these individuals reported at least having a symptom or a problem with sleep, and the frequency of those symptoms varied from having it sometimes to most of the time. And if we zoom into the phenotypes of those sleep problems, if I may say, we can see there is quite a huge range. We have most problems related to the nocturnal awakening, so the sleep fragmentation, but we also see more subjective complaints related to individuals not feeling rested after the night's sleep, which is something that is quite debated in the field, because we know that these complaints cannot be captured by objective measures, but only subjective metrics can allow us to quantify that. But we have obviously memory bias when it comes to capturing these complaints in individuals with already cognitive impairments such as MCI. But nonetheless, this shows that the subjective presence or the subjective feeling of sleep and how the person feels the next day is very important for individuals. And even though I must say the study could probably be called a historic one because it was conducted almost 30 years ago, the numbers do still hold, which highlights just how incredibly common sleep complaints and issues are in older age. But why is this the case? Why sleep problems are so common when we are aging? Well, some of this is actually due to the natural age-related changes in sleep, which are independent of the factors that you see in the slide. And one of the most pronounced age-related change in sleep is actually reduction in total sleep time, which is then accompanied by reductions in sleep efficiency. We also see increase in sleep fragmentation. And beyond these large-scale changes in sleep quality, we also see differences in sleep macroarchitecture. In this hypnogram on the right, we see that individuals that are older have lower amount of slow wave sleep and also REM sleep, which are crucial for both sleep clearance as well as emotional memory consolidation. And also aging affects sleep microarchitecture, such as sleep spindles, K complexes, which are these brief bursts of brain activity that are very crucial happening during the non-REM sleep and are related for memory consolidations and brain plasticity. So as they diminish with age, it is quite an obvious that it becomes harder for the brain thus to perform these critical functions during sleep, potentially further compounding this cognitive decline. But here's the key. We don't think that all of these changes and all of these huge numbers of prevalence when it comes to sleep problems are only explained by these factors. We also have another important features that I would like to highlight in this slide, which is medical conditions, medication use, as we know that older adults tend to be over-medicated, unfortunately, on different therapeutics, and also the high prevalence of other chronic disorders. And it is a natural progress of process of aging. As people get older, it's more common to develop chronic health conditions, and these can then really affect sleep. So while aging in itself does change sleep, those additional factors may probably have even a bigger role in why so many people experience sleep struggles. And with that, I would like to move to our main topic of today, so the relationship between sleep and preclinical Alzheimer's disease. But before I'm talking about the preclinical stage, I actually have to start with the Alzheimer's disease patients, because that's where our field, in fact, originated from the clinical practice, where we have known that Alzheimer's disease patients, especially those in the later stages of the disease, experience severe sleep disturbances. And these can be related to increased sleep fragmentation, also reductions in slow wave sleep, REM sleep. And I would like to highlight that sleep fragmentation has in fact been associated to greater has been linked with greater dementia risk. And all of these sleep changes that we see in Alzheimer's disease patients have been postulated to be related to the undergoing neurodegeneration that in fact affects those sleep-wake regulating centers. And some of the preclinical evidence actually supports this evidence whereby sleep is seen as a byproduct of Alzheimer's disease. And there is a study by Rowe and colleagues from Washington University at St. Louis where they showed that amyloid beta plaques accumulation leads to altered sleep wake cycle, which kind of clearly says to us that, well, it's Alzheimer's disease pathology that then leads to impaired sleep. But actually, more recently, the research flipped the statement by proposing that perhaps sleep is not merely a byproduct of neurodegeneration, but a potential risk factor for the disease development and progression. And one of the first and seminal studies actually came in 2009 by Kang and colleagues, where they showed that if you sleep deprive an animal model of Alzheimer's disease, they used mice in that study, they showed a significantly more amyloid plaque accumulation in the brain of that mice model. And a few years later, this was followed up in a different species. So the study was done in a Drosophila fly, fruit fly model. And again, it was found that after sleep deprivation, Drosophila fly accumulated amyloid beta in the brain, which also nicely points to this cross-species generalization of sleep as a risk factor for Alzheimer's disease. But for us, obviously, the most interesting is what is happening in humans. And we do have a few very eloquent experimental work being done. So one was done by Brandon Luce and colleagues, where they showed that after a single night of sleep deprivation, there was an increase in CSF amyloid beta production, and that influx was by 30%. And another very important neuroimaging work by Chokri and colleagues was done in 2018, which added an additional complexity to this, whereby showing the topographical accumulation of amyloid beta following the same sleep deprivation paradigm. And they found that after one night of sleep deprivation, amyloid accumulated specifically in the hippocampus, which is the early and incipient region of AD-related neurodegeneration, but also in thalamus, as we know, the key orchestrator of sleep wake cycle. So these are the key studies that provide the basis for this other side of the coin, whereby sleep is seen as a risk factor for Alzheimer's disease. However, there are only a handful of those studies, and when it comes to human studies, most of them were done in healthy and young adults. But it probably could be very difficult to convince the ethics committee to sleep deprive elderly individuals or MCI and AD patients to get these causal relationships. But that is why in the recent decades we have actually seen a proliferation in epidemiological and clinical studies looking into what is happening with sleep in cognitively healthy adults. And we found, and evidence found from epidemiological huge cohorts that subjective sleep problems are associated with increased odds, risk, and hazard ratio of developing cognitive decline as well as Alzheimer's disease. And more importantly, clinical evidence showed in cognitively impaired adults that not only subjective sleep metrics such as PSQI, but also objective and more nuanced sleep features such as slow wave sleep productions, but also slow wave activity frequency differences are related to both amyloid and tau pathology, and to a lesser extent to brain structure. So these studies then actually add more evidence to this other side, whereby sleep potentially is exacerbating Alzheimer's disease pathology. So the picture that emerges is complex. It's like a two-way street. or as we like to call it in our field, the bidirectional hypothesis between sleep and Alzheimer's disease, whereby both Alzheimer's disease pathology worsens sleep, but also sleep prior to the cognitive decline may also increase the risk of developing AD. And that's actually the side that I have decided to pursue my research, and the side that I'm going to be talking about today, because I'm mostly interested in how sleep changes may increase one's susceptibility to Alzheimer's disease down the line, and if perhaps we could find this inflection point where these changes start happening, and perhaps then start thinking about the interventions that could potentially lead to the slowing or the delaying the onset of Alzheimer's disease development. So with that, I would like to move to one of my personal works, which I published, which was published last year, and it came from the time when I was in Boston. So in this paper, what we did, we wanted to explore the relationship between sleep microarchitecture features and Alzheimer's disease pathology. And particularly, I was interested in tau accumulation, which I will explain why. Because in our field, the majority of the studies and what I've described before focus on the fluid measures, but we still have relatively little evidence on how sleep is related to neuroimaging PET markers of AD, but it's very important to study. And one of the reasons is because fluid CSF provides a distinct information from the neuroimaging findings on positron emission tomography. So CSF actually allows us to understand or gather the information on pathology in the form which is soluble, so more representative of what is happening early in disease continuum, whereas PET provides a fibrillary form of accumulation of pathology and gives additionally the important topographical information. As all of you neuroimagers know that really well, because it's important for localization, for the specificity, and also carries clinical implications. So therefore, I was really interested to investigate what is happening with tau PET levels, given that also tau is very sensitive and actually better tracks with cognition. So in the study, we used full polysomnography, with an exception of not having a video recording, because we did these polysomnography recordings at individuals' homes because we wanted to increase the ecological validity of our study. In terms of Alzheimer's pathology, as already mentioned, I looked into tau PET measured with floor tau superior, and specifically I was interested in the ROI of temporal lobe composite, because this is the incipient region of tau accumulation. And we also had measures of amyloid, which was done based on amyloid PETs, and we quantified the global amyloid burden. And lastly, we also included brain structure measures as measured by free surfer using cortical thickness, temporal lobe ROI. And what our analysis showed was that the lower percentage of slow wave sleep, so the non-REM 3, was significantly associated with a higher tau PET signal in this medial temporal lobe ROI. But what was quite interesting, that even if it was a small sample, 39 individuals, we saw that this effect was also significant in the smaller subregions of the MTL, such as the entorhinal cortex and inferior temporal lobe, which are in fact the incipient seeds of tau accumulation, and these are very fine structures. So that was a very strong evidence for us. And then we were obviously interested, perhaps this relationship that we see is related to the global amyloid burden in these individuals. And when we corrected our analysis for amyloid burden, in fact, we found this relationship to still be significant, which points us to suggest that the relationship we see is not dependent on amyloid, or at least amyloid measured by PET. And then, given the high prevalence of obstructive sleep apnea in elderly population, we also corrected our analysis but by AHI index, and we found these associations to be still significant. Given that we had also measures of cortical thickness, we wanted to see whether this is potentially related to the downstream metrics of neurodegeneration and neuronal loss. And what we found was very similar with the previous slide, whereby again, lower percentage of slow wave sleep was associated significantly with a lower cortical thickness and this greater temporal lobe ROI. And again, it was independent of amyloid PET and obstructive sleep apnea, which of course prompted us to consider some alternative mechanisms and non-amyloid pathway, which we thought could potentially explain our findings, is neuroinflammation. So the activated microglia and astrocytes activity in response to tau. And also in the study, we couldn't rule out additional comorbidities, chronic diseases, and potential of vascular burden as well, which would actually be worth examining. So in summary, this is one of the few studies that actually looked into objective sleep metrics, sleep microarchitecture, slow wave sleep, and fibrillary tau accumulation in the preclinical stages of Alzheimer's disease. And even though it's a small sample, as we know, the PSG studies are difficult to have at a greater scale, but it points to the direction and contributes to the existing literature suggesting that slow wave sleep is definitely an important and potential risk factor for Alzheimer's disease, and also suggests and paves potentially a way for augmentation techniques that could lead to improvement of slow wave sleep. And we are seeing this experimental research happening in the field, so using neuromodulation methodology or acoustic closed loop stimulation in order to increase slow wave sleep. And currently what we're seeing is that these studies do show some effect of slow wave sleep augmentation, but there is very little translational or downstream effects in terms of cognition. But probably in a few years these evidence are also going to be available. So now I'm going to briefly talk also about the neurodegeneration, because obviously this is the downstream effect, and it's interesting to explore that apart from the core ID pathology. And when we look deeper into the landscape of sleep and neuroimaging markers of neurodegeneration, we actually see that the evidence in this area are quite scarce, and especially with respect to the underlying mechanisms. So we do have some subjective studies that looked into total sleep time, where they found this inverted U shape, whereby both shorter as well as longer sleep is related to the subsequent atrophy in the frontotemporal regions. And also we have some evidence from the global sleep quality metrics such as PSQI, suggesting also that baseline metrics predict greater atrophy across the similar regions. Additionally, we have a handful of studies that look into objective measures, and these studies employ actigraphy. And the consistent and important finding coming from these studies is that it's sleep fragmentation, which I also alluded to in the previous slides, that is related to the thinner cortical structures in the orbitofrontal areas. And also very important work I would like to highlight by my colleague Claire André, where they found that it's not only the sleep fragmentation, but actually the variability in sleep fragmentation. And this is very important because we know that sleep is not a static process, it's rather a dynamic, fluctuating process that changes from night to night, from week to week, and we even see seasonal changes. So what they found was that it's actually sleep fragmentation variability that was related to thalamus atrophy and the hippocampus hypermetabolism in cognitively unimpaired adults. And even though these studies do shed some light on this relationship between brain structure and sleep disruption, they do have smaller sample sizes, or they also suffer from some limitations when it comes to neuroimaging approaches using single ROI based analysis. But most importantly, unfortunately, they didn't control or they didn't involve Alzheimer's disease pathology biomarkers, therefore making it difficult to disentangle where this relationship is coming from and what could explain this. So in this next study, I was actually trying to jump into that knowledge gap and try to patch it a little bit. And in this study, which was published quite recently, I think a few months ago, in Alzheimer's and Dementia, We used the cohort from the BBRC, the Alpha Plus study, which is a longitudinal cohort that is aimed to characterize and understand changes happening in the preclinical stages of Alzheimer's disease. But given it's a longitudinal study, we are now in the third they're now in the third visit, and we also see some individuals that already progressed. So it gives this great opportunity to study these individuals across time and how different markers and different risk factors relate to Alzheimer's disease pathology and cognitive decline. So within this greater Alpha Plus cohort, we created an embedded study called ENIGMA-Sleep, which was aimed to actually map and characterize sleep alterations in these individuals, both using subjective and objective measures. And in this specific study that I'm going to present today, we used actigraphy. So our participants wore Philips ActiWatch for a period of 2 weeks, and we did cross-corroboratory analysis with sleep diaries, which the participants did at home on their mobile phones to cross-validate the markers data from the ActiWatch. And in terms of the structure correlates, we obviously use the cortical thickness from the free surfer. And we did these 2 sets of analysis. So first of all, we went with an a priori temporal lobe composite ROI, but we were also very much interested in the exploratory regions, which were not done in previous studies that much, but also because we were interested whether this effect is solely related to MTL or there are potentially other regions that are also susceptible. And in this cohort, we also had access to Alzheimer's disease pathology biomarkers, thereby allowing us to tease a little bit apart these relationships. And what we found was actually quite a nice carryover from the study that I presented before from Harvard, and also from Andrew Lim's work, whereby several worse subjective sleep metrics were associated with lower cortical thickness in early region vulnerable to Alzheimer's disease pathology, such as lower sleep efficiency, higher sleep fragmentation, both measured by WOSO and sleep fragmentation metric. But what is very interesting and important here, and the novelty, is that in fact these changes that we saw in the MTL were completely independent of Alzheimer's disease pathology as measured by CSF. And we then, as I said, went down the exploratory analysis rabbit hole, and what we found was a very consistent and nice pattern whereby worse objective sleep metrics were not only associated to lower cortical thickness in the MTL, but also other regions such as the posterior cingulate, precuneus, as well as supramarginal gyrus and orbitofrontal cortex. And you may know that these areas are the ones early affected in Alzheimer's disease pathology, but also very important in sleep alterations such as orbitofrontal cortex that has been linked has been found in studies with insomnia patients. But probably the most fascinating evidence, at least for me, from the study is in fact the sex differences and this modifying effect of sex highlighting the female vulnerability. So what we found when we did the sex interactions and further down the stratified analysis was that not only in the medial temporal lobe, but also in some other structures such as supramarginal gyrus and the temporal pole, these effects that we saw before were significantly driven by female, suggesting that female sex is associated with lower cortical thickness in these areas as a function of worse sleep metrics, and exemplifying this female vulnerability in the preclinical Alzheimer's disease in response to worse sleep patterns on the brain structural metrics. So why do this observed sex differences important, and why do we actually need to look into sex differences in our analysis? Sorry for preaching a little bit here, but I do think this is a very important area. Well, because we obviously know that Alzheimer's disease disproportionately affects women, with about 2/3 of AD patients being female. And it's not, in fact, just because women live longer. We now know it also translates into differences in the underlying pathology, since women also show higher rates of tau accumulation and different cognitive trajectories. And there are several mechanisms that could be involved, such as obviously hormonal fluctuations during the transitional period, such as perimenopause and postmenopause, but also genetic risk factors and even reproductive events happening earlier in life, such as pregnancies, miscarriages. And when we now turn to the other side of the slide, we also see that there is a sex dimorphism in sleep field. So we know that women do complain or tend to report more insomnia and sleep disturbances, but when we quantify sleep of men and women under objective measures, we actually see that women tend to have better sleep efficiency, lower sleep fragmentation, and even so, women show more preserved slow-wave sleep, which is obviously an important marker when we're talking about aging and Alzheimer's disease. So despite the significant female paradox, women's health factors still remain critically understudied. And I would like to bring these stats into the picture. So in the left bottom of the slide, you see this amazing graph of how many imaging studies have been published in the past 25 years. And if you try and zoom in, which could be very difficult, because the line that actually shows the amount of studies that used women health specific factors is so tiny, because it's only less than 1%. And I have to say that we have done a lot of neuroimaging studies, more than 50,000, and it's such a small fraction that actually considered these sex-specific questions or variables that could explain these effects that we are seeing in Alzheimer's disease and sleep, but also in other different disorders, which really makes this a major research gap. And in fact, one of my current projects is actually set to investigate it, and even though it's out of the scope of this presentation, I would be happy to discuss this with you later on. And before I close off, I would like to give a little bit of an attention to obstructive sleep apnea, because this is by far the most common form of sleep disordered breathing, accounting for almost 80 cases in the world. And I would probably dare to say that it's a single most potent risk factor, sleep-related risk factor, when it comes to Alzheimer's disease and dementia. Although we all know sleep hasn't made into the Lancet 24 Commission of Modifiable Risk Factors, but the reasons for it, it's the other story for the other day. But the evidence is quite compelling for OSA, and I hope that this upcoming slide will allow you to appreciate that. So just to briefly remind you the physiology of obstructive sleep apnea. So it happens when the soft tissue in the upper airway collapses during sleep, leading to repeated episodes of breathing pauses. And when we look at the prevalence rate of obstructive sleep apnea, it's actually huge. It's way more than just sleep and insomnia. It's more than almost 1 billion adults worldwide experience obstructive sleep apnea, which makes it 1 in 8 adults from 30 to 69. And if we zoom into the right side of the slide, we could look into how these numbers translate into the older populations. And this was a great study based on the population study in Switzerland, Colaus. So this embedded Hypnolaus study looked at more than 2,000 community dwelling older adults, and they found really remarkable rates of obstructive sleep apnea, whereby in individuals aged over 60, they had high rates of moderate, but also moderate and severe sleep apnea, and these rates were relatively similar across sexes. So this is why I kind of call obstructive sleep apnea a big elephant in the room, because it's big. The prevalence is huge. It's really obvious. Yet we tend to ignore it, and it leads to huge underdiagnosis and therefore a lot of untreated cases, especially in the populations most at risk of Alzheimer's disease. So why is obstructive sleep apnea so important when we talk about Alzheimer's disease related changes and cognition? So actually there are a few mechanisms by which OSA may lead to increase in Alzheimer's disease pathology, from intermittent hypoxia, which causes oxidative stress, increases risk of diabetes and hypertension, to sleep fragmentation, which disrupts the glymphatic clearance via the reductions in slow wave sleep, to the intrathoracic pressure swings, which also lead to impairments in the exchange between CSF and ISF. So over time, these changes compound and contribute to the neurodegeneration and cognitive decline. And I would like to now mention a few studies that actually consistently shown these changes. So important evidence, particularly compelling, comes from, again, longitudinal studies. And on the left side, we see the study from Osari and colleagues, which show that individuals with sleep disordered breathing in the green line showed a younger age of developing MCI and Alzheimer's disease in comparison to those without sleep disordered breathing, as shown in blue. Also, work from Liguri and colleagues in Italy demonstrated that people with obstructive sleep apnea performed also worse on memory, intelligence and executive functioning tests. They also had reduced sleep quality than those treated with CPAP or those without obstructive sleep apnea. And what is important is that we also see consistent links with Alzheimer's disease biomarkers. So we see that obstructive sleep apnea is related to lower CSF amyloid beta 42 concentrations, also higher total tau amyloid beta. Also some work has shown from Sharma and colleagues that specific OSI indices such as AHI, and specifically AHI of 4%, were also linked to annual decreases in CSF amyloid beta 42. And just to interpret it, so the decrease in CSF of amyloid beta 42, not the ratio, is actually a marker of Alzheimer's amyloid beta plaques. And also some important work from Michael Bubu's lab in New York has showed that in cognitively unimpaired individuals, obstructive sleep apnea participants had a faster annual increase in fibrillar form of amyloid as measured by amyloid uptake on PET. So taken together, these findings do suggest that OSA not only is related to cognition, but also plays some role in Alzheimer's disease biomarkers and even in their longitudinal accumulation. And in addition to some global effects, again, I like the neuroimaging because it brings us this regional specificity and topographical information. I wanted to present some of the evidence on the structural correlates of OSA in individuals with risk of dementia. And the study on the left side from Australia has shown that in middle-aged and older adults with subjective cognitive decline in MCI, obstructive sleep apnea related hypoxemia was actually associated with reduced volume in the temporal pole and the right fusiform gyrus. So you can probably remember these regions from my own research findings and some of the previous slides again. So we see some consistent patterns affecting the structural brain regions. And also I'd like to highlight the work by Claire Andre, where she found that also sleep disordered breathing was associated with amyloid accumulation in the posterior regions, but also that was linked to changes in gray matter volume as well as glucose metabolism. And finally, I would like to give some moment to REM related hypoxemia, because it could be especially harmful, and some studies show, especially in animal models, that REM-related hypoxemia is related to impairment in hippocampus. And in this study done by Aaron Lamb, they found that REM-related hypoxemia was associated with CA1 subfield of the hippocampus, and that the CA1 subfield of the hippocampus actually had an indirect effect. The REM ODI had an indirect effect on the memory by the mediating pathway of the CA1. And one of the more recent works, which is currently in preprint, but it's a brilliant study that I would like to also mention, talks about the cerebrovascular contributions, and specifically white matter hyperintensities that in the frontal parietal regions appear to mediate the link between REM hypoxemia, medial temporal lobe degeneration, and impaired sleep-dependent memory. So overall, we do see that there's a huge bucket of evidence on obstructive sleep apnea, and there is ongoing studies trying to understand what are the specific mechanisms, what are the specific pathways and potential comorbidities that are involved in the effects that we see on cognition. And before I close up this presentation, I would like to talk about the emerging role of orexin in AD, because in the recent AIC we saw a lot of mentions about orexin in the context not only of sleep, in fact, but actually in Alzheimer's disease. So orexin is a neuropeptide that is produced in the lateral hypothalamus, and it is a main neuropeptide that is related to the sleep-wake system that promotes wakefulness, arousal, synchronization, but also is involved in appetite. And we have several receptors. So we have orexin 1 and orexin 2 receptors, and we have some important evidence why orexin is so important when it comes to sleep. It's because the orexin loss leads to the syndrome known as narcolepsy. But when it comes to Alzheimer's disease, why orexin is becoming a player on our table when we talk about amyloid and tau is because its dysregulation is very prominent in Alzheimer's disease patients. Some animal studies show that orexin infusion actually leads to an increase in amyloid beta levels in the interstitial fluid, and some very important clinical work has also shown that there is orexin differences, and there could be a forward loop. And in this slide, you can also see this neuropathological work that is very important and adds an extra layer of potential complexity, but also potential evidence, because studies show that Alzheimer's patients that lose a large proportion of neurons in the hypothalamus, where orexin is projecting from, may be associated with tau, leading to selective vulnerability in Alzheimer's disease. So these evidence do show that orexin really sits right at the intersection of sleep regulation and Alzheimer's pathology, and we should probably change the way we thought about orexin solely as a sleep-wake regulator, but also involved in Alzheimer's disease cascade. And with that, I would like to turn to this novel therapeutic area of potential for orexin, because we have had a few agents recently approved by the FDA for the treatment of insomnia, which orexin antagonists mainly work on, and they are called dual orexin receptor antagonist, or shortly DORAs. And even though these medications are primarily used for the treatment of insomnia, they are the new type of sleep treatment medications for insomnia because they are also very well tolerated by individuals in Alzheimer's disease continuum. And there's been some interesting evidence actually coming out from animal models whereby DORAs actually showed a decrease in soluble amyloid levels and amyloid plaques. And another very interesting study by Brandon Lucy's team from WashU also showed this in humans, whereby they used a DORA called suvorexant. And they found that DORA suvorexant use actually acutely decreases p-tau 181 levels and amyloid beta levels in CSF after 36 hours of the infusion. And just before we move to the next slide, I would like to present probably the most hot evidence straight from the press, the study where they found that not only soluble amyloid and tau is related to DORAs, but in fact in the animal study they found that another DORA, lamborexant, showed actually possibility to reduce atrophy as well as reduce the hyposphorylation of pathological tau, and even they saw effects of lamborexant of the mitigation of microglia activity. So the implication and potential message is that DORAs may not only help with insomnia as the first recommendation for the drug on the package, but could also potentially be related to the soluble forms of amyloid and tau, potentially modifying the disease process well before the symptoms appear. But obviously that's to be uncovered by the clinical trials that are robust. But this is just a very, very interesting emerging area that requires more studies to be followed up. So if you're still there and you have not fallen asleep, I would like to wrap up this talk with a few takeaway messages. So first of all, I think slow wave sleep productions, when it comes to sleep microarchitecture at least, is a definitely important target because it is related to lymphatic system clearance. And what we saw from the research, both done by me and the colleagues, that it is related to incipient tau accumulation and potentially some downstream neuronal loss markers. And it's important to also acknowledge that the typical amyloid explanation does not always hold. So we need to explore expand our studies to include additional pathways. Another strong comment that I would like to make as well is this modifying effect of sex between worse sleep parameters and lower cortical thickness brain integrity, where females show this disadvantage or when it comes to having worse sleep and higher vulnerability. And finally, not to forget the big elephant in the room, it's the obstructive sleep apnea, which should be more rigorously screened in the clinical settings, but also better examined in our analysis, given that there are treatment options for obstructive sleep apnea. So with that, I would just like you to remember, if only one thing, that sleep, it is indeed a salient determinant in influencing cerebral integrity and Alzheimer's disease pathology biomarkers, and thus it could potentially augment susceptibility to cognitive decline. So thank you so much for your attention, and thank you so much for surviving all of this long talk. And I'm really happy to receive any of your questions and hopefully to have a discussion and learn a bit more about what you're doing as well in your team.